The control could be official recommendations if it's more than 30 seconds of occurrence of atrial fibrillation in a monitor. But in a practical manner, what we say is if patients develop a lot of symptoms or not, if they have to frequently go to the emergency room and get hospitalized for the arrhythmias or not, if we are able to reduce the overall burden of the atrial fibrillation for the patient and provide a better quality of life, we feel happy that we have obtained control of atrial fibrillation. About a third of the patients will be completely asymptomatic, without symptoms at all. But about 2/3 of the patient most often have symptoms, and the symptoms can be palpitations, shortness of breath, loss of consciousness, sometimes chest pain. And depending upon these symptoms, it can affect their quality of life, from preventing them from doing activities that either gives them pleasure or just everyday living. So if they do not obtain treatment, especially for these patients who have symptoms, then obviously it's going to affect their quality of life. It affects, actually atrial fibrillation is one of the very common arrhythmias that affects the economy because of loss of days from work, stay at home, frequent emergency room visit. It increases healthcare cost. And also stroke as a result of atrial fibrillation is a big stroke. So it increases mortality and also disability mainly from stroke itself. So those are all the effects of not obtaining treatment. It's not just for the control of rhythm. Anticoagulation and newer methods of treatment such as a appendage, the left atrial appendage in the left atrium is 90% source of the clots, and occlusion of that has been shown to be also equally effective as anticoagulation to prevent strokes. Atrial fibrillation leads to strokes, and the common reason for that is considered stagnation of blood in the atrial chamber. So when there is blood stagnation, especially at the time when patient converts to regular rhythm, so the clot tends to be dislodged, and the common location it goes to is the brain. It can go to the peripheries as well, causing other embolic phenomenon, but the stroke is the most common problem that we see. For the prevention, you give blood thinners. So the stagnation cannot be avoided, but the blood can be thinned enough that the prothrombotic factors in the blood can be reversed by the blood thinners. Our main role is invasive management. Of course, we do medical management as the first line for certain arrhythmias such as atrial fibrillation, but there are certain arrhythmias like SVTs where actually the ablation has been shown to be so effective and less risk associated with the procedure that it's considered first-line therapy. So ablation is a procedure where we take catheters inside the heart in a minimally invasive manner. We have the patient on the table under X-ray guidance, and in fact, the X-ray requirement is very, very little because we have advanced mapping techniques where we convert the analog signals inside the heart, digitize it, and display it in the computer as an image. And we can use that as a guide for identification of the location of the arrhythmia. And when I place my catheter of ablation at the location, I can mark it and I can go back to it without a need for X-ray guidance even. The common techniques is, we use radiofrequency for ablation, and we have pressure sensors. We can actually use the catheters, place it in the heart, and know exactly how much pressure I'm applying in the heart. We also have freezing methods. We have a balloon kind of method where we ablate, and also the magnetic navigation that I was talking about. Robotic navigations are available, and advanced mapping techniques where with just one circuit of arrhythmia, I can actually precisely localize exactly where the circuit is localized and ablate it as well. When you look at the heart itself, I tell my patients it's like a house. There's a structure, there's plumbing work, there is electrical work, right? So for the structure, non-invasive cardiologists and fixing of the structure, the cardiac surgeons come into the picture. For the plumbing work, interventional cardiologists come into the picture. And I call myself an electrician of the heart. So, so we each have a different role to play in the management of cardiac problems. To actually really educate the patients on the significance of the arrhythmias, and also the physicians, referring physicians, but they often think, like I was telling you about the atrial fibrillation, they often think that it's a one-time fix, but oftentimes the arrhythmias such as atrial fibrillation, and something that we didn't talk about, the ventricular tachycardia, as a result of coronary artery disease, myocardial infarction, dilated cardiomyopathy, those are all ongoing problems of the heart. And it's a marriage between the patient and the specialist and the primary care physician, where we all have to work together to actually help the patient in the longer run. And it's really a management rather than a treatment. There's a lot of difference in the terminologies of the patient care.